Good morning and welcome to Medicine Grand Rounds. It's really my pleasure today to introduce Ann Sheehy. And as I've been putting together next year's Grand Rounds schedule, and Nick Hahn, upcoming chief resident, is helping me, one thing I've reflected on with him and with other leaders in the department is among our most prominent and among our best speakers actually have been our faculty. And Ann Sheehy is an example of that. She's a graduate of Middleton Cross Plains High School, the daughter of Greg Sheehy, emeritus member of our department, and so she's one of this area's own. She went off to Stanford, where she distinguished herself as an NCAA qualifier and a Pac-10 conference champion in cross country, and she was also on the track team. She then went on to get her MD at Mayo and also took an MS in clinical research there. She took a minor bump in the road, becoming an intern in OBGYN at UT Southwestern, and then saw the light and went on to Johns Hopkins, where she trained in internal medicine before joining us as first a clinical assistant professor. She arose to clinical associate professor, and last year track switched to CHS track within our department. In 2012, she stepped in as chief of, initially interim and then chief of our hospital medicine division, and really has distinguished herself there as being just an outstanding leader for that division, the department, and in fact UW Health in general. She's given numerous presentations and is known for a number of topics, among them how to care for patients in the hospital with diabetes, and more recently the issues of admission, public policy issues, and one of her, I think her most recent publication in Press at JAMA Internal Medicine, she co-wrote with actually one of our lawyers here about the copy and paste in the medical record, which is really a timely and important topic. She's published 28 manuscripts, 4 book chapters. A number of newspaper publications have quoted her, and she's actually a blog contributor to JAMA Internal Medicine. Along the way, she's earned a number of awards in addition to distinguishing herself at Stanford athletically. She's won our department's Resident Teaching Award. She won the Evans Glassroth Department of Medicine Inpatient Teacher of the Year Award twice. She's been named a Madison Top Doctor, and in 2012 received the Internal Medicine Residency Professionalism Award. What also distinguishes Ann is her service. She serves as core faculty for our Internal Medicine Residency Program. She is the secretary, treasurer of the medical board, and chair of the Medical Records Committee, and will be the president of our medical board in the future. She serves on the board for a Grace Hospital, and she's volunteered her services to the Society of Hospital Medicine, serving on the National Public Policy Committee. Given her research background and her interest in public policy, she has been called upon by them and our country to provide testimony. Most recently in 2014, just this year, she attended a congressional press conference by phone as an invited participant about hospitalization and the topic of her Grand Rounds today. And actually, this month, Ann, you're going to be an invited speaker to the House Subcommittee of the House Ways and Means Committee. So really representing our department, our school, our state beautifully in terms of this very important public policy issue. So for all those reasons, I couldn't be more pleased and proud than to introduce Ann Sheehy, speaking about the very important topic, hospitalized but not admitted, the ongoing dilemma of observation status and the 2-midnight rule. Welcome, Dr. Sheehy.
Thank you, Rick, for that introduction. I think my one piece of advice for the students that Will and Paul are here, don't do 2 internships. Figure it out before you match. I have no disclosures. So I wanted to just tell you a little bit about what I wanted to talk about today. First of all, just to talk a little bit about the background of observation status and what we know nationally and here at UW Hospital. I wanted to touch on the 2 midnight rule that's come into play this last year. Talk a little bit about the Recovery Audit Contractor Program, which enforces observation status. And then talk about how we've handled observation, the 2 midnight rule here at UW Hospital. And then close with a little bit of what's out there in public policy. So what do we know about observation status? Nationally, we know observation is important because it's outpatient care and it's covered by Medicare Part B. So when a patient comes into the hospital and is a true inpatient, they're admitted, they're covered by Medicare Part A hospital insurance, which covers nearly their entire hospital stay, including their pharmacy charges. When a patient comes in under observation, this is an outpatient designation and the patient pays more out of pocket. None of their pharmacy charges are covered, and they pay a copay for every single services that's delivered, such as a lab draw or a CAT scan. And overall, our hospital is reimbursed less because of this. The other important part about observation status is that patients who stay 3 midnights in the hospital do not qualify for skilled nursing facility coverage at discharge like true inpatients do. So patients that need a nursing home come into the hospital can stay 4 or 5 nights under observation and still not get their skilled nursing benefit. So this is how Medicare actually defines observation status, and I highlighted some of the important parts of this definition. Medicare states that observation care is well defined, and this should be used as a triaging definition for patients that require further treatment as hospital inpatients or if they are able to be discharged from the hospital. In the majority of cases, this decision should be made in less than 48 hours and in usually less than 24 hours. And only rare and exceptionally should it take longer than 48 hours. So what do we know about this definition nationally? There was a nice paper that was published in Health Affairs in 2012, and this group studied Medicare observation stays from 2007 to 2009. And they found that per beneficiary over this time period, observation stays increased, the inpatient stays decreased, and observation length of stay increased by a full 2 hours over this period of time. And you can see already that the observation length of stay is already over 24 hours in this Medicare national database. It's already up to 28 hours. And hidden in this paper was a stat that over 10% of these stays lasted greater than 48 hours, again, counter to the Medicare definition. So this graph, I think, is telling. If you look at the x-axis here, this is 2004 to 2011, and this on the y-axis is the cumulative percent change. This line here is the increase in observation services over this period of time, and this is a decrease in inpatient services. So clearly, this is all Medicare data, and this is MedPAC's data, showing that we have a huge increase in observation services being delivered while we have a decrease in inpatient stays. So we decided to study this at UW Hospital. We wanted to know what our patient population was looking like. And we looked at all of our patient encounters here from July of 2010 to December of 2011, and we had 43,000 total encounters. Of these, 10.4% were observation. And only 2.7% had a status change. And that's important because, again, the Medicare definition states that this is kind of this triaging definition, that observation should be used to kind of determine whether someone is going to be admitted as a full inpatient or going to be discharged home. And that was clearly not how we were using observation status. We determine observation or inpatient status using interqual clinical criteria, and this was how we determined observation status before the 2 midnight rule, which I'll talk about next. And then we divided our patients into service groups: medicine, which was our GMed services, our hospital services, and family medicine; our subspecialty non-surgical services, which was cardiology, heme, psychiatry, neurology; and then surgical services and pediatrics. And we wanted to address these questions. Is observation well defined? Is observation truly lasting less than 24 hours and only rarely more than 48 hours? Is observation really this holding pattern designation, which I've already touched on? And which patients are most impacted by observation status? So I've shown this slide before, and what I'll show you is on the left here is our observation status patients. And again, it was 10.4% of all of our patients. And what you see here in blue is that the vast majority of OBS is medicine. So these patients are the patients that we're taking care of on the wards: the GMed patients, the hospitals patients, the family medicine patients. And a greater proportion of our inpatients were surgical. I also want to point out that we had 1,141 distinct observation codes. So again, getting at this question of whether this is a well-defined set of limited diagnoses, it wasn't what we were seeing here. What about our length of stay? So here on the left is all of our observation encounters, and this was medicine. This is subspecialty non-surgical, surgery, and peds. As you can tell, in the blue here is all of the percent of patients who were discharged in less than 24 hours. The patients in the green here on the top were the percent of patients who were discharged in greater than 48 hours. And looking at all comers, only 44% of all of our observation at this hospital discharged in less than 24 hours. 16.5%, or about 1 in 6, were staying longer than 48 hours. Medicine was worse. We only had about a third discharging in less than 24 hours, and we had a quarter of our patients staying longer than 48 hours in observation. And I'll just highlight the mean length of stay here for all comers was 33 hours and was 41 hours in our medicine patients. So again, to look at this definition, the things we were testing, is observation well defined? Obviously not. We had over 1,000 different diagnosis codes. Is observation lasting less than 24 hours and only rare and exceptional cases lasting longer than 40 hours? Our mean length of stay was 33 hours and in 41 hours in the general medicine patient population. Again, 1 in 6 of all of our observation stays were greater than 48 hours, and this was 1 in 4 of the general medicine patients. Again, this really wasn't a holding pattern designation. Patients were coming in, and observation was actually a destination designation. We were assigning that to people, and they were staying the duration of their stay in observation. And obviously, the general medicine patients were most impacted by observation, but I will ask you to stay tuned with what the 2-midnight rule has done. It's shifted this slightly. So what do we know about observation and the 2-midnight rule? Previously, as I mentioned, observation was determined by clinical criteria, and we knew this had problems. So a lot of people welcomed a change. Interqual was a checklist of these crazy criteria of if a creatinine bumped by X amount and their potassium was this, you would meet inpatient criteria. It wasn't logical to us clinically. So in August of 2013, CMS issued a final rule that took effect October 1, and it was time-based. Basically, most patients who stayed 2 midnights or less two minutes or more were now inpatient, and patients staying less than 2 midnights were observation. And CMS did this because they wanted to get rid of long observation stays. They had heard a lot of negative feedback about current observation policy. They also intended to reduce the number of observation stays. As you saw, the percent of observation encounters was increasing. They wanted to fix the problem of what they call this high error rate in short stay inpatients. CMS believed that a lot of less than 2 midnight stays that we were calling inpatient should have been observation, and they wanted to take that back. They wanted to assign observation status to these short stay patients. And they stated they wanted to put the decision-making back in the hands of physicians to determine what their patients needed and get away from these clinical tools like Interqual and Milliman. So what does a patient look like that's staying less than 2 midnights? Well, obviously this patient is acutely ill. And her prognosis is hindered by the fact that her attending physician is grossly inexperienced. But I will tell you that since I know these 2 little girls, they were out in the backyard playing soccer about 10 minutes after this picture. So the point being, this is obviously an acutely ill person who should meet inpatient status, but it gets better quickly. But let's look at a real case. So this is someone that you might see on the medicine wards, a 45-year-old woman with type 1 diabetes. She's a Medicare patient. She ran out of insulin. She presents to the ED at 1 o'clock in the morning on Sunday with somnolence, some nausea, dehydration, and no focal complaints. Her vital signs are severe, and her labs are even more severe, and she's admitted to the ICU. By Sunday night, she's markedly improved, and she started on her home sub-Q insulin. She reiterates her history that she just ran out of insulin. She hasn't been sick. It's just a medication issue. On Monday morning, after one night in the hospital, her labs have corrected. She's up ambulating, eating, and she's asking you to discharge home. By the 2-minute rule, even though this patient needed ICU care, even though her pH was less than 7, she is an outpatient. So the 2-minute rule actually disadvantages a different cohort of patients, making them observation. Notably, what's been very difficult for our hospital is if this patient had commercial insurance, we would call her an inpatient, and how our hospital can deal with different payers treating this patient differently is a challenge. So what do we know about the 2-midnight rule nationally? The OIG put out a report in 2013 using 2012 Medicare data, and they found that there were over 2 million, almost 3 million observation and long outpatient stays. 22% of these observation stays lasted more than 2 midnights. At the same time, in the same report, they found that over 1 million inpatient stays lasted 2 midnights. So if you just do the math and you look at these people flipping, you're going to say these 1,146,925 inpatients are now going to be OBS, and the 639,940 patients are now going to be inpatient. The numbers would predict a net loss of about 500,000 inpatient encounters. In the same report, the OIG stated that CMS still expected these policies to reduce the number of observation stays. They expected a net shift from outpatient to inpatient stays, which is counter to these numbers. And to offset the costs of these additional inpatient stays, CMS proposed a 0.2% DRG payment cut across the board. So we wanted to look at what this looked like at UW Hospital, and so we did some retrospective look at, we retrospectively applied the 2-midnight rule to our prior observation encounters. We looked at our UWHC July to December data set, which included all payers, which is important because at the time we did this study, we figured that commercial payers were going to come along with our Medicare payers, and what's happened is no one has jumped onto the 2-midnight rule, not even Medicaid. So we found that there would be a net loss of over 7,000 inpatient encounters. Patients with identical length of stay in hours would have different hospital status and Medicare coverage entirely due to time of day that they were admitted relative to midnight. So to look at this, we looked at what our shortest 2-midnight encounter would be, and it was 26.6 hours. Again, this is weird, but this did happen. Someone came into the hospital 11 p.m. on a Tuesday and left at 1 a.m. on a Thursday morning. That patient stayed 26 hours. That patient meets inpatient criteria. We also had a less than 2-minute encounter that was 47.2 hours. So again, this is a person that comes to the ED at 1 o'clock on Tuesday morning and leaves at 11:30 p.m. on Wednesday night. We found that 46.9% of our patients that were staying less than 2 midnights fell into this 26.6 hour to 47 hour range, meaning that 46.9% of our patients were going to have their status determined based on the time of day they got sick. We looked at an updated database more recently, and this was a database between January of 2012 and February of 2013. So this was basically 14 months later. Our observation rate had already increased to 13.2%. As you recall, in our prior cohort, it was 10.4%. And we retrospectively applied the 2-midnight rule to these encounters. And we asked several questions of this data set, including, again, do these non-clinical factors, such as time of day of presentation, impact the chance of crossing 2 midnights? And we also wanted to know, are these patients clinically the same? So does the 2-midnight rule actually distinguish different populations of patients, making this rule logical? And this is one graph we published last month in the Journal of Hospital Medicine. So this, across the x-axis, it's kind of hard to read, so I put some text in bold. Across the x-axis is 8-hour blocks of time. So this is the time period between, midnight and 7:59 a.m. This is the middle 8 hours of the day, and this is the last 8 hours of the day. And on the y-axis is the percent of patients who would cross 2 midnights. And these were all of our observation encounters. And so we found that patients presenting for care in the first 8 hours of the day would cross 2 midnights 13.6% of the time. Patients that presented for care in the last 8 hours of the day would cross 2 midnights 31.2% of the time. And so then we thought, well, gosh, do we get a different patient population in this kind of the wee morning hours? I think anecdotally we thought, do we get some more drug overdoses, alcohol intoxication, people that probably didn't need 2 midnights to begin with? Is this a different clinical population? So we looked at the ICD-9 codes across the board, and we actually found that they were the same. There was no significant differences in the ICD-9 codes, regardless of time of day, meaning that truly time of day of presentation and not different clinical needs were going to dictate insurance benefits for these patients. So we also wanted to look at the ICD-9 codes across 2 midnights. And so up here I have all observation encounters, and these were our top 5 that stayed less than 2 midnights, and our top 5 that stayed greater than or equal to 2 midnights. And as you can see, 4 out of 5 of our top ICD-9 codes were the same regardless of length of stay. When you looked at our adult general medicine observation encounters, it was the same. They were all the same except for 1, which I've highlighted in italics. So essentially 4 out of 5 patients of our top ICD-9 codes were the same regardless of time of day, meaning that their insurance benefits and their classification for the exact same clinical scenario was going to be determined by the time of day they got sick. So again, we found that there were major problems with the 2-midnight rule. Again, do non-clinical factors such as time of day of admission impact chance of crossing 2 midnights? That's exactly what we found. Are less than 2-minute observation counters distinctly different than these greater than or equal to 2-minute observation counters, making this dividing line logical and fair? And again, we found that that was not the case. So what have we found since October 1? So just a little background, and I'll talk a little bit more about what UW Health has done. Since October 1, we have applied the 2-midnight rule, and there's been a delay in actual full auditing of this rule. But here you can see, this is right here. This is the year of data leading up to the rules change. This is our Medicare rules change on October 1. And it's a little bit hard to see, but I think if you visually, you can see there's been a shift in our encounters. And I won't go into all of the details of what these numbers are, just to visually see that we are seeing a change in how we're classifying patients. We did see that our Medicare observation rate decreased slightly. This was because of the adult general medicine population, who was our long length of stay population to begin with. The observation rate went from 28.4 to 20.5%. The surgical observation rate increased, however, and this is what we were worried about. It went from 7.5% to 9.3%, and now almost half of observation care at UW Hospital is delivered on the surgical services. These are our lucrative patients, for lack of a better word, and this has been a major problem for a hospital. Our Medicare margin, because of the loss of surgical inpatient stays, has actually gotten more negative. We were at a negative 7.6% margin for Medicare encounters before the 2-midnight rule, and we've fallen to an 11.2% negative margin after the 2-midnight rule. And again, one of the other things we were fearful of this rule was that providers play to the rule that's in front of them. And again, discharge criteria is subjective. All of you that take care of patients know this. You know, if you have a patient at 5 p.m. and you're wondering, well, maybe I should keep them, maybe I should give them another liter of fluids, they might be stronger in the morning. Previously, for efficiency's sake, we may have tried to discharge that patient knowing that they were observation, knowing that their bill was going to be higher if we kept them overnight. Now, the incentives have completely flipped. And we know that if we keep that patient another midnight and we justify that stay, that patient becomes inpatient and they're covered by Medicare Part A. And we have seen a creep in our length of stay. There's been a 2.6% increase in encounters lasting longer than 2 midnights. Again, not what our healthcare system needs, but it's the reality of this rule. So I'd like to just touch on the Recovery Audit Contractor Program, the Medicare auditing program. So the RAC program was established under the Tax Relief and Healthcare Act of 2006. And the RAC program was well-intentioned. They did a demonstration project that showed that hospitals were actually somewhat gaming the system. People were labeling, patients were checking into the hospital, they were just staying for 3 midnights to get a nursing home stay and billing Medicare. Medicare realized this was happening and they did a pilot and they recouped about $1 billion in a 6-state pilot for a limited period of time. It was a lot of money. And we all hear stories about Medicare fraud, and we know this is unacceptable. But the reality of the RAC system is that these are private contractors. They're paid on a contingency for cases they audit and win, which is their exclusive funding source. So to put it another way, this is a business model that relies on audits such that whatever rule is established, whether it's a completely fair and transparent rule, the RACs need to audit it to survive. They're not paid any money by the government. It's a fee-for-service system. It's kind of like if you go out and sell vacuum cleaners. The more vacuum cleaners you sell, the more money you make. And I will say the RACs they seem like kind of salespeople in kind of a shady sort of a way. CMS and others, they've stated that this is a self-funded program. But what happens is the RACs create an enormous amount of work and rework in these audits and appeals, both for hospitals and the federal government. At our hospital, we audit about, when the RACs audit us, we appeal, our most recent data is we're appealing 92% of what they audit, and we're winning all of them. So this is, again, work and rework that our hospital has to pay for, that the RACs pay nothing for, and this is Medicare dollars that we're spending on fighting an auditing system instead of putting this money back in direct patient care. In addition, there's 5 levels of appeal, which I'll show you on the next slide. And once an appeal gets to the 3rd level, the federal government has to pay to hear that appeal. In January, the OMHA, which is the office of the government that hears these appeals, they basically told hospitals across the country that they could no longer appeal these audits because they had a 16-month backlog of cases. So hospitals are now denied their due process. Hospitals are now saying, you know, how can you do this to us, because this is work that's generated by these RACs. The number of cases that are backed up in the RAC system in the level 3 appeals are about 350,000 right now. And I know you can't read this slide, but that's the point. This is the RAC. This is the 5-stage Medicare administrative appeals process that our hospital follows. And these are the levels. So this is level 1, this is level 2, this is level 3 when you get to the federal judge, and level 4 and level 5. So again, any process that looks like this is obviously going to be wasteful. That's all I can say. And if you look at the American Hospital Association data, in the last quarter of calendar year 2013, across the country, 49% of audits are being appealed and 64% are successful. So again, our numbers are very good here at UW Hospital. We do a very good job with this. Our numbers are better than the national numbers. But again, across the country, you know, 50% of the time or more, the RACs are wrong. And there's few businesses that would survive in this country being wrong over half of the time. Again, this is another panel that you can't read, which is, again, the point. This is what our coordinated care and utilization review process looks like. And again, these are the case managers that are paging you and telling you to change statuses. They're saying that this patient, are they going to stay 2 midnights? Do they have Medicare? Do they have commercial insurance? This is the process they follow. This is an extremely talented group of case managers that are doing this. I think they do a remarkable job navigating this process, but this slide shows you how cumbersome this process is. And again, this is a look at, again, you can't read this, but this is the look at what they're doing per payer type. So it's a very complicated process that's been brought on with these complicated rules. So what has UW Hospital done? So I will say that every time I walk by this in the hallway, I laugh. UW Hospital is not good at following every rule, but we are very good at following Medicare observation rule. I know you guys have all seen that. Everyone on the ward sees that picture. So I think this has been one of the neatest things about being at UW Hospital. There's this true multidisciplinary approach with this incredibly talented, hardworking, and actionable team that involves Bart Capone and Sridevi Gangreddy on the hospital side. It's a ground-level team of expert case managers who work with the utilization review physicians, Bart and Sridevi, as needed. There's a monthly short-stay work group, which includes outcomes managers, the access center, our legal team, CMO, CNO, and utilization review physicians. There's a twice-monthly RAC PAC team. And then there's constant ongoing review of cases to prepare these cases for appeal. And this group is truly amazing in their work. Just sitting in a meeting, I mean, you just see the way that we're ahead of the game here. And I've talked on this topic nationally and on my national committee work, and people are amazed at what we're doing here at UW Hospital. It's really something to be proud of. And you all are familiar with this. This is kind of the second round of, or the third round, I should say, of the 2-midnight rule order. This, in a modified form, in a much more short form, was rolled out on October 1. This is our current order for inpatient status that now requires a certification statement. Again, we rolled this out on October 1 to all payers, and now we've questioned whether there's an impact on non-Medicare payers. Again, I think everyone thought that commercial payers were going to follow suit. We had to apply this rule to everybody coming in because we don't always know what insurance somebody has. And also our EPIC system can't customize per payer. Now we know that maybe we've labeled some of our commercial patients as observation when perhaps they could have been inpatient, and so we're looking at kind of how to deal with that scenario. Another part of this rule that you've seen is the need for the attendings to co-sign an inpatient order, and this came out with a final rule last year as well, which was new. If we discharge a patient from the hospital and the attending physician has not co-signed the inpatient order, we cannot bill Medicare Part A for that stay. In the first quarter of this calendar year, we had 57 unsigned inpatient orders, which will, if the full auditing was in effect, would have cost us almost $1 million. So I wanted to talk a little bit about observation public policy under the kind of guise of, we complain about this a lot, so what are we doing about it? And so I think that's been, for me, has been my channel for my frustration with this policy as a hospitalist, is to kind of get out there and try to change these policies. So this is a picture that I took when I was in Washington, D.C. In October during the government shutdown, and it kind of speaks to the kind of the ridiculous nature of all this. As many of you have been to the Lincoln Memorial, it's this open-air monument, and this was this little gate that you could walk right around. And I thought this sign was so funny because it said, "The site is closed, do not enter," and it kind of spoke to how ridiculous the whole government shutdown was and some of these rules and regulations. There were people all over the mall even though it was shut down. So first I'd like to touch on public policy as it relates to the fate of Two-Midnights. So we did roll out our plan for the Two-Midnight Rule on October 1, and it is the law of the land right now. But there has been a kind of a hiatus in full enforcement of this rule. CMS actually has delayed full enforcement of this rule serially 3 times now for a 12-month period of time. Just before October 1, it was like 4 days before October 1, CMS delayed full auditing of this rule for 3 months. And just before these 3 months were set to expire, CMS delayed again. And then at the end of January, CMS extended the delay for a full year. And so what I mean by this is it means that they can't come in and do a full audit of our charts like they were doing before. They have this probe and educate period where they can look at a small sample of our charts and kind of give us some advice and kind of see who's having trouble and who's not. And then, as many of you are aware, the SGR Patch that was signed into law on April 1 actually was used as a vehicle by Congress to actually delay rules enforcement for another 6 months. So now the Two-Midnight Rule has delayed enforcement until encounters that start on April 1st, 2015 or later. The Two-Midnight Rule has had a lot of other bad press, and also the American Hospital Association has been probably the most vocal on this issue. They recently sued CMS over the Two-Midnight Rule, stating, "The rule unwisely permits the government to supplant treating physicians' judgment and defies common sense. The word inpatient simply does not mean a person who stays in the hospital until day 3. So I think just to not skip ahead too fast, when I think about the Two-Midnight Rule, I think this rule may never actually be fully implemented. There was in the proposed rule this year, there was talk about a short stay DRG. CMS is looking at changing some things with the Two-Midnight Rule, and I actually think that they realize that this rule is sort of a misfit to the problem of observation status. So what about the skilled nursing facility benefit? And this has probably been the issue that I've worked the hardest on. There's a really nice bill in Congress, and again, as a disclaimer, this is all bipartisan. I think it's one of the few things in government that's been supported by both Democrats and Republicans. So I'm not advocating for one side or the other. But there is a Improving Access to Medicare Coverage Act of 2013, which is H.R. 1179 and Senate Bill 569. And this bill would guarantee skilled nursing facility benefit to all Medicare beneficiaries who stay 3 midnights, regardless of observation or inpatient status. H.R. 1179 has 144 co-sponsors right now. Again, it's more Democrat than Republican, but certainly it's split. And the Senate bill has 25. And I will say that 7 out of 8 of our Wisconsin representatives have co-sponsored H.R. 1179. I've done a lot of work with this with Representative Courtney, who's the sponsor of the bill, and I've worked closely with the Center for Medicare Advocacy. Toby Edelman is a lawyer there, and she's worked very hard on this issue as well to try to guarantee that skilled facility benefit. And then the Society of Hospital Medicine Public Policy Committee has made this one of our primary missions over the last year. And then I think RAC reform is necessary, and one of the important points that we've talked about is that any observation reform needs to be accompanied by recovery audit contractor reform. As I mentioned before, the contractors actually are paid on a contingency to audit these charts, and they are mandated to do so to keep their business model alive. So whatever observation policy CMS would issue, the RACs are going to audit it. And so I think there needs to be some reform of the RACs for any observation policy to be successful. There is the Medicare Audit Improvement Act of 2013, which is H.R. 1250, Senate Bill 1012. This is kind of a far-reaching bill that has many co-sponsors, and 6 of 8 Wisconsin representatives have signed on. Most people believe that this will never pass, however, although it has a lot of sponsors. The AHA, the American Hospital Association, has pushed very hard for this bill. This would basically devastate the RACs. It improves auditor transparency. It makes them publish the audits and appeals data. It actually includes penalties to the RACs for audits overturned on appeal. So if the RAC would audit UW Hospital, and it turns out we were right the first time, the RAC would have to pay our costs to have prepared that audit and appeal. It also aligns the look back and rebill periods. So another thing I haven't talked about is the fact that a RAC can audit our charts up to 3 years out. We can only actually appeal a chart up to 1 year out. So a RAC that starts to audit us 2 years out actually kind of has a free pass. And so it aligns these look back periods of how long the RACs can continue to look at our charts. The Administrative Relief and Accurate Medicare Payments Act of 2013 is H.R. 2329. And this exclusively aligns the look back and rebill periods. This has 20 Republican co-sponsors, none from Wisconsin. This is just a small chunk of the first bill. And I asked on a conference call this week, why have people not jumped onto this bill? It really seems to be that the American Hospital Association has pushed so hard for H.R. 1250 that they've discouraged people from signing on to H.R. 2329 because they want the full bill. So it's hard to know exactly. I think this is the politics of these bills that I don't completely understand, but it looks like H.R. 1250 has much more support, although doubtful that this will pass. And then, as Rick mentioned, on Tuesday, I've been invited to testify at the House Ways and Means Health Subcommittee on observation status, the 2-minute rule, and auditing. And the encouraging part of this is that I think if you look at the hearing advisory, the Congress is actually ready to hear about this, at least it seems. It's a bipartisan committee hearing, even though House Ways and Means is run by the Republican side. They have been very clear that this is a bipartisan hearing. They've allowed Democratic and Republican staffers to submit questions, and they know that the RAC program has generated a lot of waste. Observation policy needs reform. So I'm really excited to participate in this and hope that there can be some meaningful reform coming out of this hearing. So just to summarize, and I'd love to entertain questions if people have them, observation status remains a major problem. It is high stakes for patients. Patients are getting bills, and the hospital is losing money. The 2-minute rule is not a great fix, and I think part of my testimony that I will talk about on Tuesday is I think before we come up with another kind of fix for observation status, we really need to look at what OBS should be. So observation should get back to that initial Medicare definition for observation, meaning it should be for this very well-defined limited subset of patients that maybe need a couple extra hours attached to an emergency department visit where they may need an extra liter of fluids, maybe they need a stress test, and then they can go home. But patients coming into the hospital that are staying overnight on our wards, this is an observation, this is inpatient care. And I think until we can get back to that definition, any kind of new rule we apply to observation is probably going to have some of the same problems we're seeing now in the 2-minute rule. As I mentioned before, I think the RAC program really needs to be reformed. It's really hard to imagine any observation policy that Medicare rolls out that's going to be functional under the current auditing system. And I think importantly, UW Health has been fantastic in contributing to the national efforts to reform observation care. The people here have helped me enormously getting data. I'll say Becky Borchard, I don't know if she's here, but she was working late Wednesday night to get me some extra data for the testimony on Tuesday. I mean, this is an extremely dedicated group of people that are also dedicated to fixing this problem, and I feel very lucky to work with all the people here. So just my thanks again to our division, which is a great division, the Society of Hospital Medicine, obviously Cindy Heidke, our division administrator, Andrew and Dan, which helped me enormously with data, Sri and Bart, who are always helpful in all of this work, and Michelle, my assistant, who is also fantastic in helping me with anything I need. So thank you.
Thank you, Ann. That was just terrific. I'll ask you to call on the audience and ask you likewise to kind of summarize the comment and question for the recording.
Bennett.
That was really nice, Ann. I'm just wondering if anyone's looked at the types of patients that would be switched to their detriment. They couldn't get into a SNF, they would have more copay, perhaps by zip code of origin, to see if this would affect certain demographies in our society, adversely more so than other demographies in our society.
So the question is whether different patient demographics are adversely impacted by observation care and people that are going to be losing skilled facility coverage. So we haven't looked at that under the 2-midnight rule, but we looked at that very carefully prior to the 2-midnight rule, and we found that observation care clearly disadvantaged an elderly patient population, more likely to disadvantage females, probably a caregiver effect. A lot of people were under observation. They couldn't go home because they didn't have that caregiver at home. So we know that's certainly the case. We've looked briefly at kind of minority status in observation, and we have seen a slight uptick in minorities that are under observation. I'm not certain exactly how to explain that in our data yet, but we're looking at that a little bit more closely. So again, I think this is a vulnerable patient population that observation care disadvantages.
Clearly, it's all about money. How much money does the observation status save Medicare?
So the question is, this is all about money, and how much does this save Medicare? This saves Medicare a lot. I had the opportunity to talk with CMS in March, and they've clearly said, we said, why not just get rid of observation status? I mean, it's a question worth asking. They can't afford to do that. We know here at UW Hospital, we lose about $240 per patient day in observation care. So it's about $10 an hour per hour of observation per patient that we're losing. It's a lot. So the question is, where did the 3-day stay come from? There was actually a nice paper published in JAMA last year on that very issue, and it talked about this being this historic determination that was based on how long patients used to need to stay in the hospital to know that they needed a skilled nursing facility. There was no science behind 3 midnights. It was more just what someone picked and thought that was about the right amount of time. There have been times in history, and this JAMA paper talks about this, that they've actually temporarily repealed the 3 midnight stay, and there's been an acceleration of nursing home discharges, which has left everyone fearful of repealing the 3 midnight rule. I will say there's actually a bill in Congress right now that would make anybody who comes to hospital eligible for nursing home coverage regardless of how long they're there. And that bill has no co-sponsors, and it's because of cost.
Thanks for that summary, Ann. Really nonsensical process. What is Medicaid and what are private payers doing currently? Are they going to follow Medicare's lead ultimately?
So the question is what are commercial payers and what is Medicaid going to do? So we assumed that they would follow suit because Medicare's policies typically, have been followed by commercial payers. To date, and Bart, correct me if I'm wrong, we don't know of a single commercial payer that's followed suit, and Medicaid has not followed suit. So I think people are really seeing that, one, this rule may not stick. Number two, it's not entirely logical, and I think people are kind of waiting to see, what comes of this. We do have a much better luck with our commercial payers as far as making a case. You can talk to someone on the phone. With Medicare, it's just not like that.
First, I have an observation about observation, which is, as an attending physician, I can't tell which patients are observation and which aren't, which kind of gives face validity to this. But the second question I have is, how do you see this affecting the function of the emergency department decision to quickly make an admission decision before midnight? Has that happened? Have you seen those types of changes in care?
So the question is again, the statement that these patients are indistinguishable on the wards. I totally agree. And then the other part of the question is whether this has prompted the emergency department to kind of try to get people in before midnight. We did think that was going to happen. Fortunately, Medicare, in their rules clarification, have stated that the time that care starts in the emergency department is the time the clock starts. So if a patient is roomed and starts getting vital signs taken and labs drawn, that's when our clock starts. So they don't actually need an admission order to start that clock. We thought that we were going to be trying to get this bolus of patients before midnight when they might not necessarily be ready to come in, or they may not need to come in at all. But fortunately, that has been a nice clarification. So the question is, what is the effect of this on physician reimbursement? I can tell you, I don't know our specific physician reimbursement numbers, but I do know our hospital reimbursement numbers. And observation care is delivered at a much lower reimbursement rate than inpatient. It's significant. It depends on what type of observation patient you look at. But again, our all-comers for observation is about a $10 an hour per patient loss. The general medicine observation care is delivered at about a minus $33 an hour loss here at UW Hospital. Obviously, that impacts physician reimbursement as well.
So the rule was supposed to go into effect October 1st of 13, but you said that it's now been delayed until 2015. Will the RACs be able to audit retrospectively during that sort of free period once the 2015 rolls around?
So the question is regarding the rule being implemented on October 1 and then this delay in kind of full enforcement until April 1 of 2015. So the RACs will not be able, the rule is actually in place, and we are following it as of October 1. It's the auditing and full enforcement of the rule that's been delayed. The RACs will not be able to come back and audit in that period of time. They have this kind of probe and educate period right now where they can look at a few numbers of our charts, but this is actually, and believe me, there's a lobby for the RACs. The RACs have been lobbying Congress about this as well, saying, you know, you can't do this to us, and they want their auditing abilities back. Their tack is that they combat Medicare fraud and that they kind of ferret out waste in the system, and that's their take on their role. But they will not be able to come back and audit our charts to any significant degree during that period of time.
And speaking of lobbying, the fact that you're seeing bipartisan support for yours and the American hospice organizations suggests that the seniors are involved. And to what degree are you seeing them testifying perhaps with you or advocating on behalf of getting some sense around this?
So the question is, okay, yeah. So yeah, how have seniors been involved? So the AARP has been extremely powerful in this movement, and they've done a lot of nice publications on this topic, as has the Centers for Medicare Advocacy that's worked very closely with AARP. When I've gone to Washington, what I hear from our congresspeople and our senators is that they're hearing from these people. And so I do think that Medicare beneficiaries are calling in. I think that AARP and other organizations are doing a good job of mobilizing their members against these policies.
So I'm just looking into the future here, whether this rule holds or not in the long run. I spent an hour in my clinic the other day ruling out pulmonary embolism in the clinic with a CT angio and Doppler. An hour getting those tests done, and did so at University Hospital. Are we moving as an organization into a status of even just preventing these short stays by having things available to us in the ED, in the clinics, so that we can make a triage decision on someone with upper GI bleed and what score they have there, and just prevent these admissions in the first place? Isn't the writing on the wall that that's maybe the less expensive way to go as we become an ACO?
Right, so the question is, you know, what are we doing here at UW Health to kind of prevent these short stays altogether, kind of increasing the capacities in our clinics or around the ED to prevent these patients from coming to the hospital altogether? I mean, I definitely agree. That's the ideal scenario, is to kind of amp up what our clinics can do, to kind of amp up what our ED can do. The ED is working on an observation unit right now that can serve a small subset of these patients. I think that will be helpful. We've looked at the observation unit data as well, and it's very limited right now. It's only been tested for about 5 there's only been randomized studies for 5 diagnosis codes. And there's been a lot of exclusion criteria: people with social problems, people with difficult discharge dispositions, people with medical comorbidities that haven't met inclusion into those studies. That said, I think they do serve a certain patient population, and they can improve efficiency, and they can prevent us from getting into this situation altogether. I think we really need to look at some of those things as an ACO for sure.
I think we're going to close there, but before we do, I do want to mention that next week, Grand Rounds is going to be in HSLC. It's the kickoff for the Department of Medicine Research Day. It's 15 minutes later than this, so if you're used to coming in on Friday and arriving at this room, you've got time to walk to HSLC, and you still won't miss the beginning of that very important Grand Rounds. With that, I'd like to thank Dr. Sheehy for just a fantastic presentation today.